First of all, let me thank you, my very good friend, Dr. Ishu Aguilada, for the invitation. And just I want to make an apologize because I'm not there in person this year, but unfortunately I broke my patella and it's a long journey, so I could not travel now. So the title of this year is Women Living with HIV. And these are my disclosures. We all know that women represent worldwide the largest part of people living with HIV. And it depends on the specific area. But this you see in India is very, very, very large the proportion of women, like in South Africa, while in Europe it's more, more limited. We have around 30%, 25%. Okay. There are biological, social, and cultural factors that amplify women's inherent susceptibility to HIV. This is very clear because it depends, as I said, on the cultural things, but also we know that there could be rape and sex violence, that this is really international. There could be early and forced marriages. There could be, for example, sex work. So there are factors that are, that determine the fact that women could be at higher risk of acquiring HIV infection, and especially young women. Very young women between 15 and 24 years. This is true in Africa, especially in sub-Saharan Africa, but I think that is also true in other parts of the world. In low and middle income countries, the vulnerability of women is very high because we know that 7 out of 10 women who are living in conflict setting and refugee population undergo sexual violence. You know that sexual violence and rape is considered by men like a weapon. It's a war strategy. And obviously, women who have experienced violence are 50% more likely to be living with HIV. And we have also to think that this is during the war, but we have many women who have been physically and sexually abused by their partners. And this one, especially if there was a forced marriage or, an unequal relationship. And I mean, this leads to mental health issues, including depression and anxiety, but we'll talk about this later. Something that is really, really important is the stigma. The stigma about HIV, and now especially the self-stigma, This is a study that has been recently published and has been conducted in Western India. And it's a sort of questionnaire on about around 40 women. And they show that there is an intersectional stigma of HIV and domestic violence. And when you have domestic violence, the stigma is amplified. Also, the fact that there are multiple stigma, this worsens domestic violence, and the stigma of HIV hides domestic violence. So it's something that as clinicians, we should always investigate. We know that for our people living with HIV, we are like GPs. So if they have to talk about something like that they argue with their husband, they have problem with their kids, they come and they tell us. So it's important to investigate also domestic violence in order maybe to help these women. It's not only that they acquire HIV infection when they are very young, but HIV represents the first cause of death in women of this age between 15 and 49 years old, globally, obviously. So let's talk about prevention. This is the situation, but prevention. We don't have the pivirine ring in Europe, but we know that for women, cisgender women, the only really approved is FTC tenofovir, diproxyl fumarate. So it's important that women it's important to create data in order that women can go on on-demand PrEP or TAF. So, and we will see also about the injectable that is approved for now in the US, but not easily available. This is a very recent study that has been published last year, and about 11 trials, including on PrEP, including tenofovir diproxyl fumarate and FTC, in 6 countries. 21% of the enrolled were women coming from India. They are all women, and what we can see is that the rate of incidence rate is absolutely similar. The total rate is absolutely similar to that of men who have sex with men, and that, as in men who have sex with men, the the protection, the level of protection increases with adherence. So they are not different. Why I'm underlining this? Because there has been data previously showing that maybe that could be some concern about tenofovir concentration in vaginal mucosa. So women they could not go on demand PrEP. They could not. They have to wait more than 1 week of daily PrEP in order to consider themselves protected. But these data on such a huge number of cisgender women, we are talking about more than 6,000 women, show that really the difference is not there. Talking about the injectables, these were the first data on the injectables on cabotegravir, showing that this injection every 2 months was superior to tenofovir FTC taken once a day. We know that the problem of women is that they are not so well adherent to, especially because they are very young, they are not so well adherent to pills. So it's possible to reach superiority. And if we look at the women who did the injection in time, and they were adherent, the number of infection was zero. And 0 was also the number of infection in the purpose 1 with lenacapavir. Lenacapavir is a very interesting long-acting because it is it is administered every 6 months. So in high prevalent country could be a great surrogate for a vaccine that is not there. And the results of this study that showed also the data on TAF that we were looking for, which are not really different from the one of tenofovir, you will see. But what is incredible is about the results of lenacapavir. The other thing that I want to underline is that, the median age is very, very low, because these are, especially in South Africa, you see also Uganda, this is the population that is at risk, who are at risk of acquiring HIV infection. Very, very young. And you see in lenacapavir, no, absolutely no infection, while it was much higher, the percentage of, you see, there was no difference almost about from the background HIV incidence. That was the method in order not to have a control group, and the FTAF FTC tough and FTC and tenofovir. As I said, women, young women, especially in Africa, they don't take the pills every day. So the availability of a long-acting, we know that also VIV is looking to to prolong the effect of cabotegravir until 4 months, and this will be important. It will be a matter of prices. But having 2 injections per year and 0 incidence is very important. We know that this is true in women. In MSM there were 2 infections, but in women this is a game changer. Why it is important? Because the results on the vaccine, and this is the Imbocodo trial that is using the mosaic vaccine. You see the 2 curves with placebo and vaccine were totally overimposable. So no effect of the vaccine. So talking about the management of HIV, of women living with HIV, when we talk about heart, we have several heart considerations. We have to look at on the basis of the time of their life that the women are when they are diagnosed. So we can have women of childbearing potential if we think at the age of women enrolled in the PrEP trials. They are all obviously of childbearing potential, but also we have to talk about women in menopause and older age. When we talk to them, we have to talk about U equal U, because the stigma is so high, as we have seen. And so it's important to talk about U equal U. But also it's also important to talk about contraception counseling, cancer and precancerous lesion screening, vaccines, pre-pregnancy counseling, but also menopause, sexual dysfunction, but also situations like isolation, economic instability. The vast majority of women living with HIV, they don't work. So they are absolutely easy to be blackmailed by men and dominated by men. Difficulties in accessing healthcare, stigmatization, and partner violence requirement. So this is something that we have to ask. When we talk about heart, the general consideration is that this is the ARIA trial with dolutegravir, abacavir, 3TC compared to atazanavir, ritonavir plus FTC and tenofovir diproxil fumarate. But what I wanted to say is that the FDA has asked that there should be a specific trial in women in order to test the efficacy in women. But the result has been always very, very similar to men. The only difference is when you go to some minorities where the effect of the treatment is just, it's a part of their everyday life that is more difficult than in other countries. So you see that, for example, compared to white African heritage people have a lower response. So it's just like others, it's important to look at that. So when we have to select antiretroviral, we have to consider, for example, if it's in a childbearing potential, because we have to think about unplanned pregnancy. I have to say that after the long, long story with dolutegravir, now we don't have drugs that are contraindicated in pregnancy. We lack some data. And these data are very important, for example, for dolutegravir 3TC on the injectables, and I will talk about this in a moment. So about women who can have an unplanned pregnancy, but also older women who have an increased comorbidity risk, cardiovascular, bone, decreased kidney function, mental health. And for all women, we have to think about contraceptive and hormone replacement therapy, antidepressant. I don't like this idea that women are always depressed, but we have to investigate if they are depressed. lipid lowering and hypoglycemic agents, and calcium supplementation. Sometimes women are depressed because men make them depressed, but this is just the European guidelines to show you the interaction, but also obviously the website of the University of Liverpool that is the most useful to use in the clinical practice when we are in our ambulatory. So the most important thing when there is a woman who wants to conceive is that we have to maintain her viral load suppressed. So we have to look if investigate if the treatment that they are on, it's well tolerated, because they don't have to discontinue it, okay? But also we have to look at a sexually transmitted disease, because they can enhance the risk of transmission to the child. So it's important to evaluate at least these two things, but the idea that the viral load should be undetectable should be the mantra along all the pregnancy. But we have to talk to them about the mother-to-child transmission program, what we are doing. Because if these are again data from India, they show that if women are aware of the mother-to-child transmission program, they adhere much more than if they are not aware. So we have to take some extra time to explain them what is the risk of mother-to-child transmission, what is breastfeeding, what is, how they will deliver, and so on. Now, as I said, we were looking for data on dolutegravir 3TC that we don't have, but we have some data, a few data that are coming about pregnancies. These are the data from HPTN 084, that it was the one that I showed you on African women in injectable PrEP. And what we have seen is that at least cabotegravir did not show any problem during pregnancy. So this is something that is very reassuring. There was absolutely no difference in all these fetal outcome. Breastfeeding, I know that in India the women living with HIV, they should breastfeed for the first 6 months, while in Europe we recommend against breastfeeding. We recommend formula milk. But I have to say that we have a lot of migrants from Africa for whom breastfeeding is very important from a cultural point of view. So what we should do is just to follow them, assist them with breastfeeding. So this is important, and controlling the viral load. After delivery, it's important to take into account depression, postpartum depression. And these are again data from India with a systematic review and meta-analysis showing that there is a higher risk of suicide if there was depression during pregnancy and postpartum, unplanned pregnancy, intimate partner violence, undisclosed HIV status, lack of social support, and recent diagnosis of sexually transmitted infection other than HIV. They all represent a risk factor for suicidal ideation after delivery. So it's important to investigate this factor and to talk to our women. When we talk about comorbidities, we know that while the life expectancy of people living with HIV is very similar to that of the people living without HIV, we know that the time spent without comorbidity is much shorter. And when we talk about mortality for comorbidity, we see, these are data from France, that in women is even more relevant than in men. So it's important to consider, to look for comorbidity, because we always say, women live longer, but it's not true. With HIV, it's not true. We have to look at the comorbidities and treatment as much as we treat them in men, especially because in women living with HIV, the cardiovascular risk, for example, is twice that of men, because non-calcified plaques are more common. We have an incidence of pulmonary hypertension that is 40% higher. We don't know about hypertension. The risk of stroke is higher 2 or 3 times. So and we know that we can have more weight gain, a lower BMD, and so it's it's important to evaluate. And looking at the weight gain, we know that the data in women are, there was a greater in the advanced trial, greater weight gain in female than in males. When this is the impact, when they are pregnant, we have to take into account that if there is a greater weight gain, especially in low and middle income countries, maybe it's good. And actually there were data showing that an unfavorable outcome of the child was related to a lower maternal weight. Finally, cancer screening. We have to, these are the guidelines, European guidelines, but mammography every 1 to 3 years, starting from 50, cervical pap or liquid-based cytology or HPV test every 1 to 3 years in women older than 21. But, older than 21 depends if they start to have a sexual activity when they are 12, maybe we can do it even early, and anal exam or anal cytology or anoscopy every 1 or 3 years for those who have HPV associated lesion. Menopause in HIV women, just to say that we don't prescribe enough hormone therapy as a prevention for cardiovascular disease. This is a study that was conducted on the WISE cohort, showing that those who are on hormone replacement therapy had 43% lower prevalence of plaque, and also the intima media thickness progressed much lower than in those without hormone replacement therapy. So it's important to prescribe it to our women. And this is just the intima media thickness. Women are less studied than men. And it's not a problem of low and middle income countries. This is from Canada. This is from the United States, calling for more inclusion of women in cure studies. And important in Canada, for example, and you see it's very recent, in 2022, key recommendation for developing a national action plan to advance the sexual and reproductive health and rights of women living with HIV in Canada. So we have to talk about women, and I thank you for the topic. In conclusion, women represent worldwide the most affected population, and we really have to do any effort to prevent HIV infection. We have great progresses in concerning married to child transmission and the safety of antiretroviral in pregnancy. Women are caregiver always, and this has an impact on adherence and treatment outcome, and they should be taken into account when tailoring antiretroviral regimen in this population. And particular attention should be taken in monitoring side effects, for example, weight gain. Many aspects of menopause should be investigated and monitored. And I thank you for your attention.